Imagine experiencing microscopic tears in your skin
Uh,
over and over again in one of the absolute most sensitive parts of your body.
right, just constant irritation.
Yeah, exactly. You're dealing with friction, burning, and just this kind of searing pain that makes something that used to be wonderful feel, well, completely impossible.
It's devastating.
It is. And now imagine taking the courage to actually walk into your doctor's office to get help for that pain, and they essentially just give you a collective shoulder shrug. They tell you, well, that's just a normal part of getting older.
Which is a staggering and frankly heartbreaking reality. I mean, for decades, the medical establishment has essentially normalized female pain,
Yeah.
particularly when it comes to intimacy after menopause. We're sort of conditioned to accept structural decline in the female body as a given.
Yeah.
A foregone conclusion rather than a mechanical, biological issue that can actually be addressed.
And nowhere is this more obvious than when we talk about sexual wellness for postmenopausal women. So we are doing a deep dive today to tackle a question that is incredibly personal, deeply stigmatized, but so vital for you to hear.
Absolutely vital.
The question is, can a regenerative treatment known as the O-shot actually help if intimacy becomes painful after menopause?
It's a question that affects just a massive portion of the population. Yet because of the taboo surrounding both menopause and, female sexual pleasure, it just remains shrouded in silence for so many women.
It does, and the numbers in the stack of sources we're looking at today are honestly jarring. I mean, we are talking about anywhere from 17% to 45% of menopausal women reporting that sex has become painful.
Yeah, that is millions upon millions of women worldwide.
Right. And a primary culprit behind this is this physiological condition called postmenopausal vulvovaginal atrophy, or VVA.
Which is a very sterile clinical term for a highly disruptive physical reality.
Yeah.
And I want to set the scene for how we're going to look at this today.
Oh.
If you could see my backdrop right now, it's shifted to a rendering of a cellular matrix. Just softly glowing, interconnected webs of tissue.
Ooh, nice visual.
Thanks. That's intentional. My goal today is to cut straight through the marketing hype that often surrounds aesthetic or sexual wellness treatments. I want us to look at the clinical data and explain the actual biological mechanisms at play.
Let's do it.
Because beneath the catchy O-shot name, there is some really profound cellular science happening.
Okay, let's unpack this, because for far too long, women have been handed a narrative that they just have to accept diminished sexual function.
Right, the whole grin and bear it mentality.
Exactly. Vaginal dryness, painful intercourse, which the medical literature calls dyspareunia, these have just been dismissed as inevitable. It's almost treated as a punchline in pop culture, right? Like the idea of the sexless older woman.
It is, yeah.
But it fundamentally impacts a person's relational health, their emotional well-being, and, their core connection to their own body.
It does. It really does. And to understand why we have this massive problem, we have to look at the mechanics of the menopause transition. Estrogen is essentially the key structural architect here.
Okay.
Before menopause, estrogen's job is to keep the vaginal lining thick, highly elastic, and well lubricated. It supports this robust network of blood vessels that keep the tissue oxygenated and healthy.
So it's essentially acting like the mortar in a brick wall, keeping everything sturdy and resilient.
That's a great way to look at it.
Yeah.
But as estrogen levels drop dramatically during perimenopause and menopause, that tissue physically changes. It literally atrophies.
Wow.
Yeah. The vaginal lining thins out significantly. It loses that elasticity, meaning it physically cannot stretch the way it used to. And the glands that produce natural lubrication essentially just go dormant.
So when you introduce friction during intercourse into an environment that is now fragile, dry, and lacking elasticity...
You're asking for trouble.
Right. It's not just uncomfortable. You are causing genuine trauma to the tissue.
Precisely. You are inducing microtears and significant inflammation. It is a very real, acute pain response.
Which raises a glaring question for me, and I'm sure for anyone listening. If this structural collapse is affecting up to 45% of menopausal women, why is there such a massive treatment gap? Why are so many women just suffering in silence?
Well, it's a combination of that lingering societal stigma we mentioned, combined with the severe limitations of our traditional treatments. Let's look at the standard therapies.
Okay.
Over-the-counter lubricants and moisturizers are always the first line of defense. But they're essentially temporary band-aids. They reduce friction in the moment, but they do absolutely nothing to change the underlying health or thickness of the tissue.
Right. They don't rebuild the wall. They just make the crumbling bricks a little slippery.
Exactly. Then you move up the ladder to hormone replacement therapy, specifically localized topical estrogen creams or rings. For many women, this is highly effective. It replaces the missing architect and the tissue responds.
But the sources make it very clear that it's not an option for everyone.
Far from it. First, some women simply do not respond to topical estrogen, no matter how consistently they use it. Their tissue has atrophied past the point of a simple hormonal fix.
Oh, wow.
Yeah. And more importantly, a significant number of women have strict contraindications to hormone therapy.
Like breast cancer survivors.
Yes, exactly. Women with a history of estrogen receptor-positive breast cancer, or those at high risk for it, are generally strongly advised by their oncologists to avoid estrogen treatments altogether, even localized ones.
That's rough.
So for decades, if a tube of lubricant didn't solve your pain and hormones were off the table because of your medical history, your doctor essentially threw their hands up. You were out of options.
Which leaves a terrifying void in care. I mean, if hormones aren't the only answer, how can the body be coaxed into healing itself? And that brings us to the actual intervention we are diving into today.
The O shot.
Right, which stands for the orgasm shot. And the core of this treatment isn't some new synthetic pharmaceutical drug. It's something called platelet-rich plasma, or PRP.
And the origin of this treatment is fascinating because the medical community did not invent PRP for vaginal health. It was pioneered well over 15 years ago, primarily by researchers and doctors like Dr. Charles Runels, to heal complex, stubborn sports injuries in elite athletes.
Oh, wait, I've heard of this. Like if an Olympic tennis player tears a tendon or a pitcher blows out their shoulder, they use PRP injections to regenerate that joint tissue so they can avoid surgery.
That is exactly the same underlying technology.
Okay, so let's translate this from an athlete's knee to intimate wellness. To me, looking at the literature, PRP is like isolating your body's own specialized construction foreman.
I like that.
Right, because you go into the clinic and they draw a small amount of blood from your arm, just like a standard annual lab test. Blood is basically a river made of different components: red blood cells, white blood cells, and platelets. So they take your blood and spin it at high speeds in a machine called a centrifuge. This separates everything, allowing them to isolate just the platelets into this highly concentrated serum. And then they inject that concentrated liquid gold right back into the vaginal and clitoral tissue.
What's fascinating here is the precise molecular signaling that happens the second those platelets are reintroduced into the tissue. We generally think of platelets just as the things that clot our blood when we get a paper cut.
Yeah, the scab builders.
Right. But they're actually packed with autologous growth factors.
And autologous meaning it comes exclusively from your own body, no foreign substances.
Correct. When we isolate them in a centrifuge, we are concentrating these specific molecules. Two of the heavy hitters are vascular endothelial growth factor, or VEGF, and platelet-derived growth factor, or PDGF.
Okay, I have to stop you there, because throwing around acronyms like VEGF and PDGF doesn't really tell us what is happening under the microscope. What do those growth factors actually do to stop the pain?
Let's break down the mechanism. They act as biological megaphones. When they're injected into the thinned-out, atrophied vaginal tissue, they essentially wake up the local stem cells and fibroblasts that have gone dormant since estrogen left the building.
Ah, the dormant construction crew.
Yes. For example, VEGF,
Right.
vascular endothelial growth factor. Vascular means blood vessels. This specific molecule's entire job is to stimulate angiogenesis, which is the creation of brand new microscopic blood vessels.
Wow.
It literally builds new piping to flood that starved area with fresh blood supply, oxygen, and nutrients.
So it's fixing the desertification of the tissue by literally building new aqueducts.
And alongside that, you have other growth factors stimulating the fibroblasts to synthesize collagen type 3. This is the structural protein that gives tissue its plumpness and stretch. They're rebuilding the structural integrity of the vaginal wall.
Right.
And on top of that, these growth factors enhance neuroregeneration, meaning they repair and sensitize the local nerve endings.
So this is why it's a paradigm shift. It is not masking the pain with a lubricant. It is fundamentally rebuilding the architecture of the tissue that menopause depleted.
It is cellular regeneration. The body is using its own blueprints to heal itself.
Okay, well, I have to be the voice of the listener for a second because I know exactly what everyone is thinking right now.
I can guess.
We are talking about taking a needle and injecting it into the most highly sensitive, easily irritated, intimate areas of the female body, let alone tissue that is already causing someone severe pain. That sounds objectively terrifying. It sounds like medieval torture.
It is the single most common fear, and it is completely understandable. The idea of a needle anywhere near the clitoris or the anterior vaginal wall induces anxiety in almost anyone.
Yeah.
But the clinical reality of how the procedure is performed is quite different from what you're picturing.
How so? Because a needle is a needle.
It comes down to the pain management protocol. The entire appointment takes about 30 minutes, but the actual injection phase is only a few minutes. Crucially, a medical-grade, highly potent topical numbing cream is applied to the target areas well before any needles are brought out.
Okay, so you don't feel it right away.
Right. And in many clinics, they also use a local anesthetic block, similar to what a dentist might use, but specialized for the pelvic floor, just to ensure the area is completely deadened to sensation.
Our sources emphasize this point heavily, actually. Once that numbing takes full effect, patients report that they feel pressure, but they do not feel a sharp, stabbing pain. It's designed to be a highly tolerable, essentially painless experience once the anesthetics are on board.
And because it is a minimally invasive injection, there is virtually no downtime. The numbing wears off over the next few hours, but patients can resume their normal daily activities immediately.
Some of the clinic data even notes that you can have intercourse that exact same day if you wanted to.
You can.
So the theory sounds incredible. We are regenerating blood vessels and collagen, and the procedure itself seems highly manageable. But let's move past the theory. Does the clinical data actually back up these regenerative claims? Especially when you put it head-to-head against the traditional treatments we talked about.
This is where we have to look closely at the peer-reviewed literature, because for a long time, the O-shot existed purely in the realm of clinical anecdote.
Here's where it gets really interesting. Let's look at a specific clinical study published in the medical journal Frontiers. They designed a trial with 66 postmenopausal patients who were all suffering from that painful condition, VVA.
Right.
They gave 36 of them the traditional gold standard treatment, topical estrogen. The other 30 were given the PRP injections.
But the brilliance of this study is in how they selected those 30 women. They didn't just pick average patients. They intentionally selected women who had already tried topical estrogen in the past and had absolutely no response to it.
They deliberately tested the hopeless cases, the ones where modern medicine had already thrown in the towel.
That is a vital detail in clinical research design. You are testing your new therapy on a population that has already failed the established standard of care.
Yeah.
Now, the challenge in a study like this is, well, how do you measure pain? You can't just take a blood test to see if someone's sex life has improved.
Right. Pain is subjective. So how do they quantify the results?
They used validated, highly standardized medical questionnaires administered at regular intervals. The primary tool is the Female Sexual Function Index.
And this isn't a magazine quiz.
No, it's a diagnostic tool that asks patients to rate specific metrics on a scale. Their level of physical arousal, their natural lubrication, their ability to reach orgasm, and crucially, the severity of pain during penetration. They also use the Vulvovaginal Symptoms Questionnaire to track daily discomfort, itching, and dryness.
So they're tracking very specific, granular metrics over time. And at the 12-week mark, the results they published were undeniable.
Very clear.
The group treated with PRP again, the women who couldn't be helped by estrogen, showed significantly better scores across the board compared to the estrogen group. Their pain dramatically decreased, their natural lubrication improved, and their overall sexual function scores spiked.
It's a compelling finding. It suggests that PRP isn't just a fallback alternative for those who can't take hormones. It might actually be a superior, more profound restorative option because it addresses the tissue architecture directly.
And it's not just one isolated study with 66 women. We also pulled a massive 24 systematic review from the Journal of Sexual Medicine.
Which is huge.
Yeah. A systematic review is when scientists look at all the high-quality studies ever done on a topic and aggregate the data. This one encompassed 327 women across multiple trials. And the consensus of all that data, PRP was found to significantly improve sexual function, vaginal health, and decrease sexual distress.
However, we do have to apply a critical thinking lens here. If we are looking at the same data, we have to acknowledge the caveats. As promising as these results are, the authors of that 2024 review explicitly noted that further research is needed to prove PRP's efficacy conclusively.
I'm looking at that right now, and it makes me wonder if 327 women across multiple studies showed significant improvement, and athletes have been using this for almost 2 decades, what is holding the broader medical community back? Like, why isn't every gynecologist in the world offering this as a first-line treatment?
It comes down to standardization, or rather, the lack of it. Because PRP is a relatively new application in the field of gynecology, there is no universally standardized FDA-approved protocol yet.
What does that mean in practice?
It means that if you go to Clinic A, they might draw a certain amount of blood and spin it in their centrifuge at 3,000 RPMs for 5 minutes. But if you go to Clinic B across town, they might spin it at 4,000 RPMs for 10 minutes.
Oh, I see.
Yeah, the resulting concentration of platelets will be different. The exact dosage injected, the depth of the needle, the specific injection sites, all of these variables still fluctuate widely across the medical field.
So it's like having a great recipe for a cake, but every baker is using slightly different oven temperatures and measuring cups. You know it's going to be cake, but the quality might vary.
That is a perfect analogy. The underlying science of autologous growth factors is incredibly sound, but it is not a standardized universal matching bullet yet.
Right.
The medical establishment requires massive, multi-center, double-blind, randomized controlled trials to establish the singular, optimal protocol before it becomes the standard of care.
That makes total sense. We are still in the optimization phase of this science. So keeping that nuance in mind that the exact preparation might vary slightly depending on your provider, what should you actually expect if you decide this is the right path for you and you walk into a clinic tomorrow?
The timeline of results is one of the most important things to understand because we live in a culture of instant gratification. And because we are talking about actual tissue regeneration, it is not an overnight switch. You don't get the shot and instantly have the tissue of a 20-year-old the next morning.
Right. If you're relying on a biological construction crew, they need time to build the house.
Exactly.
But our sources do show that many patients report one specific change very quickly, an increase in natural vaginal lubrication, sometimes within just a few days of the procedure.
Yes, and that aligns perfectly with what we know about VEGF. The stimulation of new blood flow that angiogenesis process happens relatively quickly. The improved circulation immediately brings more hydration to the tissue, but the deeper structural benefits take longer.
Okay.
Over the following weeks, usually peaking around the 3-month mark, patients report the more profound shifts.
This is when the collagen has actually had time to synthesize.
Exactly. The new collagen type 3 provides that much-needed elasticity and thickness, and the nerve regeneration takes full effect. This translates clinically to a drastic decrease in pain during intercourse, heightened arousal, and increased physical sensitivity.
Now, as I was reading through the clinical data, there were some really surprising bonus benefits that kept popping up.
Oh, definitely.
Because you are injecting this plasma into the anterior vaginal wall and the clitoral area, you aren't just fixing painful intimacy. The sources highlight that the O-shot is highly effective at treating mild to moderate stress urinary incontinence.
Which is incredibly common after childbirth and menopause.
Right. That's when you leak a little bit of urine when you laugh, cough, sneeze, or, do jumping jacks at the gym. But how does fixing vaginal pain magically fix your bladder?
If we connect this to the bigger picture of pelvic anatomy, it makes perfect mechanical sense. Think of the anterior vaginal wall as a hammock.
Okay, a hammock.
Sitting directly on top of that hammock is the urethra, the tube that empties the bladder. When menopause thins out that vaginal tissue, the hammock sags. It loses its structural integrity, so the urethra isn't properly supported.
Got it.
When you laugh or sneeze, the pressure pushes down, the hammock gives way, and you leak.
Oh. So by injecting PRP and rebuilding that vaginal wall with dense new collagen and blood vessels, you are essentially pulling the hammock tight again. You are providing better physical structural support to the urethra from underneath.
Precisely. You are tightening the scaffolding, which reduces or eliminates those stress leaks. It's a profound secondary benefit.
That's amazing. It's also being used, according to the literature, to ease symptoms of chronic, painful dermatological conditions like lichen sclerosis, which causes severe itching, tearing, and scarring of the vulvar tissue. It really seems to act as a multi-tool for pelvic health.
It really does.
But I want to make sure we're being totally transparent with everyone listening. This is advanced medicine, but it's not a miracle. Let's talk about the limitations.
And there's several. First and foremost, we have to temper expectations regarding longevity. The results of the O-shot are not permanent.
Because your body is still aging, right? You haven't stopped time.
Correct. The biological clock is still ticking. The new tissue you've built will eventually undergo the same natural aging processes and estrogen deprivation that the original tissue did. Clinical data shows that the regenerative effects typically last anywhere from 12 to 18 months.
So, practically speaking, if this works for you, you will likely need to schedule maintenance shots every year or year and a half to keep that tissue healthy and robust.
Yes.
Yeah.
Furthermore, the O shot is not for everyone. While the risk profile is exceptionally low compared to pharmaceuticals because it uses your own blood, there is zero risk of an allergic reaction or rejection. There are strict
You
contraindications.
should avoid it.
Women with certain blood disorders, active pelvic infections, or those currently undergoing treatment for active cancers are not candidates for this procedure.
So, what does this all mean? If you are listening to this deep dive right now and you've been dealing with the pain or the dryness or just a quiet, devastating loss of intimacy that is affecting your marriage or your relationship with yourself, how should you weigh this option?
It means you have choices that simply did not exist 20 years ago. You no longer have to accept a doctor shrugging their shoulders. For women with estrogen contraindications, or those who have tried hormones and failed, or those who simply prefer a natural approach using their own biology, PRP offers a powerful, scientifically grounded tool. It should be viewed as a highly effective piece of a comprehensive, personalized menopause management plan.
It really represents a complete narrative shift in how we view the aging female body. Menopause does not mean the end of intimacy. It does not mean you have to quietly tolerate physical pain to maintain a connection with your partner. Through the regenerative science of PRP, the OSHA is offering a non-surgical, proactive way to rebuild tissue health, drastically decrease pain, and let you reclaim your sexual wellness on your own terms.
The most important takeaway from all of this data is that sexual health has no expiration date. Yes, the body changes, but we now have the medical technology to meet those changes head on. Opening up these conversations with your healthcare provider, pushing past the taboo to discuss these deeply personal symptoms, is the vital first step to finding relief and taking back your quality of life.
It's about refusing to accept that the machine just has to break down and stay broken, which leaves us with a final, lingering question to ponder as we wrap up today's deep dive. If our own blood just spinning in a centrifuge holds the latent blueprint to completely rebuild and rejuvenate our most intimate, sensitive tissues, what other inevitable aspects of physical aging might we soon be able to reverse just by figuring out how to tap into our body's own internal pharmacy?